All right, everyone. It was wonderful to see you all today. And sorry, we didn't have enough time to go into the case study 2 discussion. So I'm going to use this time and to go into the case study 2 discussion. So this case is of Fiona. Fiona is a ballet dancer. She's a 35-year-old ballet dancer who was well until 1 week ago. And at that time, she developed central abdominal pain with nausea and she vomited twice. The pain then shifted to the right abdominal quadrant where there was an extreme tenderness and palpitation and acute appendicitis was diagnosed. She was operated on, inflamed appendix was removed, and she appeared to be making uneventful recovery, right? However, on the second day, of the operation, he suddenly developed a sharp stabbing pain over her left chest, which was made worse by taking a sudden inspiration. So at that time, she noted dyspnea. She developed cough with a small amount of blood-streaked sputum. Fiona is a non-smoker and has no history of lung disease. However, she's been taking oral contraceptives for 10 years. All right, so let's see. What tests would you perform first? First, what you're going to do is for sure you're going to do physical examination. You kind of like have some data that she has dyspnea, difficulty breathing and inspiration, and then you also saw, where the pain is. The pulmonary function test, given that she has difficulty breathing, dyspnea, and, especially inspiration, so you're going to do spirometry. And you will also do DLCO, right? Sometimes, spirometry doesn't tell you enough what's going on. If there's anything in the alveoli also, that's why you'll do DLCO. You will for sure do arterial blood gas analysis to see how the P arterial O2 is and P arterial CO2 is. That will give you some sort of indication of how the gases are in the blood, especially given the fact that she has dyspnea. Capnometry, because you want to see what the CO2 levels are, arterial CO2 levels. You will do ventilation perfusion scans, and I'll get to that, why we will do that. That's always, useful to do whenever you have things like post-operative, complications. So the sixth one, which is basically what you would do is a D-dimer test. D-dimer test is degradation of the fibrin clot. So this is how the ventilation perfusion scan would look like. Ventilation looks like it's normal. As you can see, the spread when you use a radiolabel xenon, there's a nice spread of your radioactivity on the scintillation counter, the lung. With respect to perfusion, you see that everything looks okay except for this small area, right? Looks like this is where not enough of blood is going. So that would actually be indicative of pulmonary embolism, right? This wedge-shaped appearance when you look at the VQ scans that you can notice, and that'll tell you that perfusion is impaired. So the diagnosis for sure, I gave you a lot of hints, and this is pulmonary embolism. What are some of the clues which you had in the question, the case when it was presented? She was operated on, an appendix was removed, and she was making recovery. So whenever post-operation, complications could happen, clotting and everything. On the second day of the operation, she suddenly developed this sharp stabbing pain over the left chest, right, which was made worse by taking sudden inspiration. So this should tell you there's something to do with the pulmonary circulation. Given that, there was, surgery which just took place. Dyspnea, she developed also a cough with a small amount blood-streaked sputum. Blood coming into sputum, that's really an alarming sign. That means there's some stuff which is oozing out of the lungs, out of the blood into the lungs, and that if it is blood streak, that means somehow the blood or materials are getting into the lungs. So we'll get into that, how it kind of like transitions or spills over to another kind of disease. And the fact that she's been taking oral contraceptives for the last 10 years, this is another big clue which would suggest that this individual has pulmonary embolism. Now, there are different reasons why pulmonary embolism can develop. One of them for sure, if individual has been on bed rest for quite some time, because there's not enough circulation of flow, there's a stasis, and then that can actually make the blood to kind of become static, and that can lead to clot formation. Same thing with the long flights. If somebody takes a long flight and they don't move much, And, that's why in flights they tell you to, move your legs, move your body, walk around. If the flight crews let you walk, right? And that's the other reason why, the stasis of blood can happen. Again, car trips, people do this trip from like, Los Angeles all the way to New York in 24 hours. They don't move at all. It's really crazy when you hear about that. So that's something which you can see. In pregnancy, especially in pregnancy, due to the hormonal changes, the entire, basically, coagulating factors are elevated, same as that of when individuals taking birth control pills. Oral contraceptives will also basically elevate the levels of coagulants, and that could lead to clot formation. Now, in pulmonary embolism, what really happens is somewhere in the lower extremities of, lower legs, this clots, which as a result of stasis, laying down on the bed, long flight, or any of these other reasons we talked about, the clot would be formed, and then that blood clot, it gets pushed through your systemic circulation and comes into the right atria, and then it gets into the right ventricle. And then in right ventricle, it gets into the pulmonary circulation right here. When it gets into the pulmonary circulation, it goes and gets lodged into your pulmonary capillaries. So what will happen when it gets lodged into those pulmonary capillaries? This clot, like accumulating right here, it's going to prevent and it's going to impair the blood flow through this pulmonary capillaries. And that is what is the pulmonary embolism, right? So the clinical features for sure will depend on the size of the embolus and any of the pre-existing condition or the pressure changes. So any kind of like small emboli that gets easily cleared by lungs, and that's one of the functions we talked about in the beginning of pulmonary circulation lecture, that it does help you clean, remove, filter some of the small clots and all that also. But if it's larger in size, large enough that it cannot be cleared, that's what leads to embolus. And then that's how you can basically, in clinic, it will be presented as a chest pain, respiratory distress, and, and hypoxemia is something when there's not exchange of gases going on. So therefore, your arterial PO2 is going to be lower, and that's the hypoxemia condition. Now, this is the pulmonary vascular resistance. It is given by vascular resistance in both alveolar vessels and extra-alveolar vessels. Alveolar vessels are the ones which are surrounding your alveoli, right? And then the ones which are in the spaces between the alveoli, those capillaries are called as the extra-alveolar vessels or extra-alveolar capillaries. Now they behave very differently and they respond to pressure differences differently, lung volume changes differently, and therefore they'll have different vascular resistance also as a result of that. So PVR, total pulmonary vascular resistance, is addition of both your alveolar capillary vascular resistance and the extra-alveolar capillary resistance. So this is the main difference between the systemic and the pulmonary circulations. In systemic circulation, with an increase in cardiac output, your vascular resistance is also going to increase. However, in pulmonary circulation, with an increase in cardiac output, your pulmonary vascular resistance is going to decrease, right? All right. Now, there are three main mechanisms by which the pulmonary embolism happens. First, we looked at the slowed blood flow stasis. We talked about individual who's on bed rest, and taking a long flight, driving for a long time. They're not moving their body. They're not moving their legs and calf muscles, the ones which will help to push the blood through the veins against the gravity. When that's not happening, the blood is going to start to become static. And then that would basically activate a lot of these clotting factors, and that will initiate the clotting cascade, and that can lead to the blood clot formation. This is also, I'm talking about these three reasons, which I had them in my recordings, but then I took this all the due credit to osmosis. You don't need to go through osmosis. I've taken a lot of stuff from osmosis, so due credit to them because I have membership. I'm not taking free stuff from there. There I learned that these three factors which I were talking about, the reasons, these are called as the Werker's triad. And the second one being hypercoagulation. There is increasing amounts of clotting factors if they are present, like right after the surgery, as what Fiona, our ballet dancer, went through. That would damage the vessels and the clotting cascade would increase. That's the natural response, physiological response. Individual Fiona on birth control pills, that actually increases the clotting factors, and then the anticoagulants basically start to go down. That would be another reason for the pulmonary development of emboli. Genetics is another factor. Some individuals do have this clotting, increase clotting factors, and that could cause the hypercoagulative state. The third one is the damage to blood vessels. This can happen during the infections, during chronic inflammation, and especially in an individual who has been doing tobacco smoking for a long time. Although Fiona doesn't have any history of smoking, but she does have birth control for almost 10 years and had surgery. So these are the two main reasons by which you can actually say that she does have pulmonary embolism, right? Now, what would be the other consequences of pulmonary embolism? Remember, we talked about as a result of pulmonary embolism, there would be an increased pulmonary vascular resistance. With an increasing pulmonary vascular resistance, the right ventricle is going to try very hard to push the blood through the pulmonary arteries into the pulmonary circulation, but there is a clot right here, so it's going to try very hard to push the blood, and therefore the right ventricle is going to work really, really hard, and that would lead to dilation of the right ventricle. That would lead to hypertrophy, initially physiological, later on becoming pathological hypertrophy, and that leads to a condition called as cor pulmonale, where as a result of lung dysfunction, the heart starts to dysfunction, cor pulmonale. In this case, there's enlargement of right ventricle. So with the reduced left ventricle filling, given that your right ventricle is starting to malfunction as a result of that, when the blood is going to go through the pulmonary circulation, there's not going to be enough pressure or blood getting into the left atria. And then given that there's not enough blood coming into the left atria, there'll be reduced left ventricle filling, and there will be lower cardiac output, and there will be lower systemic blood pressure. Hypotension can happen. What would happen to the gas exchange? Remember, we talked about in the physiological dead space when we were talking about. So basically, physiological dead space is a mix of anatomic dead space and the space of the wasted ventilation by the unperfused alveoli. So in this case, what's happening is this is an alveoli, and this is your pulmonary circulation, pulmonary capillary going. Your alveoli has normal arterial O2, right? But then your clot has basically blocked this pulmonary circulation capillary. So therefore, your O2 is whatever is in the deoxygenated blood. The CO2 is not coming here. As a result of this, these alveoli are ventilated, but they are not participating in the gas exchange. So these are unperfused alveoli. So what would they contribute to? They would contribute towards the physiological dead space. So the physiological dead space would increase. And as a result of that, there would be an increased difference between the alveolar partial pressure of oxygen and the alveolar partial pressure of oxygen. Arterial, sorry. Therefore, there will be a decreased oxygen delivery to the tissue, which will cause hypoxia, decrease oxygen in the tissues, and that can lead to organ damage eventually. In really, really severe cases, and it's not typical of pulmonary embolism patients, but then given that Fiona, she also showed that along, with the noted dyspnea, she has developed a cough with small amount of blood streaked sputum that shows that there is filling up of alveoli with something which is actually coming up on cough, right? So in some cases, this pulmonary edema also can happen as a result of pulmonary embolism. So in pulmonary edema, basically with an increased pulmonary vascular resistance, the hypertension will increase the hydrostatic pressure. Hydrostatic pressure is the pressure which the blood is exerting against the pulmonary capillaries. As that pressure is increasing, it is going to try to push the fluid into the interstitial space. So this is your normal pulmonary capillary, and this is your alveolar, which is right next to it, and this is the interstitial space. When the pressure here, hydrostatic pressure or pulmonary hypertension, that's going to increase, that's going to push the fluid into the interstitial space for now, right? With the interstitial fluid being pushed into the interstitial space, that'll cause the interstitial edema. In normal conditions, this interstitial fluid is easily cleared by the lymphatic circulation. But in this case, the amount of fluid into interstitial space is so high that it is not being effectively cleared by lymphatic system. That leads to interstitial edema because it's in the interstitium. In severe cases, when the hydrostatic edema, hydrostatic pressure, and also the other oncotic pressure will increase, that would lead to even the fluid getting into the alveolar spaces. That's what was caused the alveolar edema, and this is what might be going on in Fiona's case, because she has alveolar edema going on. That's why she's coughing up this pinkish sputum. Now, accumulation of fluid in interstitial space, we talked about, we explained this, and this impairs, again, exchange or diffusion of gases, because what does the diffusion depend on? Area. It depends on the thickness. The thickness here would increase when the alveoli are full of this liquid, and even in interstitial edema, the interstitial spaces are full of this fluid, so therefore the thickness is increasing. And the area which was earlier participating in the gas exchange, that area is also going to go down. So therefore your diffusion, the rate of diffusion is going to go down significantly. That's what's going to happen to your diffusion. Pulmonary edema, basically here we use an equation called the Stirling equation. Stirling equation is a relationship between the hydrostatic pressure and oncotic pressure, and it keeps into account the permeability coefficients, the permeability of the capillary, and also the reflection coefficient. So basically, within the Stirling equation, you have hydrostatic pressure. The capillaries will have certain amount of hydrostatic pressure, and the interstitial space, that will also exert some amount of hydrostatic pressure because there's some fluid, right? And the oncotic pressure is the one which is exerted by the different proteins and all molecules which are present in the blood capillary, and also in the interstitium, instances in case of infection and all that, the proteins and other molecules will start to accumulate in the interstitium, and that would increase oncotic pressure. Kf here is given by, Kf right here, Kf is given by the conductance, that is the capillary filtration coefficient. This is what it's going to determine how much of filtration, of how much of pushing of fluid is going through here. And that can also get altered in case of disease conditions, especially in case of infection. The sigma this is a reflection coefficient. This is a measure of leakiness of the capillary endothelium, how leaky this capillary endothelium is. And that will also depend on, if the walls are ruptured, endothelium is ruptured, in a lot of spaces, and in infection this happens. So hydrostatic edema is when your hydrostatic pressure difference is higher. Due to the hydrostatic pressure difference being higher, this tall arrows of the hydrostatic pressure is going to push the liquid from capillary into the interstitial space, right? The permeability edema, on the other hand, where the capillaries are more leaky, and because when they become more leaky, the protein contents are going to start to ooze out into their interstitial space, right? As a result, the interstitial space oncotic pressure is going to increase. When that happens, remember the process of osmosis, the fluids, the water is going to start to move from lower osmotic pressure to higher osmotic pressure, and therefore this will start to fill up your interstitium here. Now, there are two types of hydrostatic edema. There is cardiogenic and non-cardiogenic hydrostatic edema. The cardiogenic hydrostatic edema, where the reason is due to the cardiac malfunctioning. And if the left ventricle is not functioning properly, is not pumping properly, there would be a back pressure which would start to build. And due to that back pressure, in instances of congestive heart failure, that would lead to increasing pressure, increasing hydrostatic pressure, and that would lead to more seeping of fluid into your interstitial space. The non-cardiogenic hydrostatic edema, which is not depends on the cardiac, but then it is what we've been talking about, the pulmonary hypertension, happens as a result of pulmonary embolism, and the pulmonary vascular resistance increases. As a result, you will have accumulation of fluid. That would be non-cardiogenic hydrostatic edema.